Hello, and welcome to the Mentation Workflow Training Module for the Richmond Health and Wellness Program. By the end of this presentation, you should be able to, number one, recognize trends of depression and cognitive impairment as it relates to older adults. Two, know which screening tools can be used to identify depression and dementia in older adults. And three, follow the appropriate procedure to identify participants at risk for depression or cognitive impairment, screen and assess for the situation, and make the appropriate recommendation or referral for these participants. This image demonstrates that the percentage of Virginians over the age of 65 is projected to increase over the next couple of decades. It is predicted that by 2040, 1 in 5 residents will be over the age of 65. Dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairment. These impairments range from Alzheimer's, which is the most common, to frontotemporal dementia, which is the least common. Some adults can also present with mixed dementia, which is a combination of the various types of dementia. Some adults with dementia will experience agitation, while others may present with aggression. Participants can also have a cluster of symptoms, which can include depression and apathy. The prevalence of the disease has increased since the beginning of COVID-19 pandemic in 2020. According to the Alzheimer's Association, 16% of senior deaths have been related to dementia. Older adults are also at an increased risk for depression. Misperception of depression symptoms by healthcare providers as a normal reaction to illness and life changes often leads to misdiagnosis and undertreatment of depression in older adults. The prevalence of depression in older adults in the community is 1 to 5%. Prevalence rises to 13.5% for older adults needing home health and 11.5% for older adults who have been hospitalized. The Institute for Healthcare Improvement developed the age-friendly health systems to improve outcomes in the care of older adults, utilizing the 4Ms framework. RHWP has been recognized as an age-friendly program and utilizes the 4Ms as a framework for our participant visits. The 4Ms consist of what matters, medications, mentation, and mobility. As you begin to work with participants, you will find that there is often overlap when discussing these 4 areas. The focus for this training module will be on mentation, which encompasses cognition and mood. When engaging participants in discussion on their mentation, it's important to keep in mind the entire framework and also consider mobility, medication, and what matters most to the participant. Mentation encompasses dementia, deliria, and depression. We know that medications may play a role in delirium and depression, while what matters to a participant may play a role in their depression. For the purposes of this training, we will focus on screening for dementia and depression as part of mentation. Participants should be screened utilizing a validated screening tool such as the PHQ-9, depression scale, or the Mini-Cog. We will now cover how to assess, recognize signs of cognitive impairment, and resources available for those with cognitive impairment and dementia and participants at RHWP. In REDCap, on the left-hand side of the participant profile, you will see screening tools that can be utilized during the wellness visits, such as the Mini-Cog. The Mini-Cog is a validated tool that is quick and easy to perform. It consists of 3-word recalls, such as apple, penny, and table, to assess a participant's memory, followed by observing the participant's ability to accurately draw a clock. Here's a more in-depth look at how to score a Mini-Cog. It's fairly simple to score. However, results are not diagnostic and require follow-up with a physician. For scoring, the participant gets 1 point for each word they can recall without any cues. For the clock draw, the participant will be scored based on whether the hands are drawn to the correct time that was asked, and also for the correct placement of numbers, and if all members are present. The participant gets 2 points for a normal clock and 0 points for any abnormal clock drawn. Scores of 3 or greater indicate a lower likelihood of dementia, but does not rule out cognitive impairment. The participant could still be experiencing some degree of impairment. Scores lower than 3 indicate cognitive impairment, but is not diagnostic of cognitive diseases like Alzheimer's and dementia. For more details, an instructional video on how to perform and score a Mini-Cog can be found in the resource folder. It's important to know when a participant should be screened for cognitive impairment. Screening at the time of enrollment allows RHWP to establish a baseline for the participant. After that, screening should be implemented whenever there is clinical suspicion of cognitive impairment or the participant has reported changes in their mental status. This may include a decline in their memory or changes in their thinking or mood. Dementia, particularly Alzheimer's disease, is genetically linked. If there's a family history of Alzheimer's or other types of dementia, it could warrant cognitive impairment screening. A faculty member should always be informed if this assessment is performed at RHWP, as it is extremely important to approach this with sensitivity. Medications can contribute to a participant's change in mental status. Always assess the participant's medication list to identify possible culprits. Some common medications to look out for include anticholinergics such as diphenhydramine or Benadryl, opioids such as hydrocodone, benzodiazepines such as alprazolam, and sedative hypnotics such as Ambien or zolpidem. A more complete list of medications for each drug class is located in the resource folder on Canvas. It's also important to consider a person's mobility and functional status when assessing for cognitive impairment. An increase in risk of falling and changes in functional abilities are commonly seen as a person becomes more impaired. The falls risk checklist found in REDCap can help reassess a person's rising risk and can help the RHWP team address modifiable risk factors. Adding exercise to a person's daily routine has been shown to improve cognition. This is an example of how the RHWP workflow should take place if a participant requires screening for cognitive changes. The Mini-Cog assessment should be approached with sensitivity. Educate the participant about the exam, highlighting their strengths and strategies to manage and support their brain health. The RHWP team will make referrals as appropriate. Once a participant has been screened, it's important to know how to educate them on brain health or things the participant can do in order to help with their cognition. These items include counseling on proper blood pressure and glucose monitoring, weight loss, proper nutrition, maintaining good sleep habits, and finding ways to remain engaged in their community, reducing alcohol intake and avoiding smoking. For those who score poorly on the Mini-Cog, the RHWP team can also help them find ways to manage memory deficits in their daily life. Setting alarms and timers, using a notebook for jotting down things that they don't want to forget, getting a weekly pill box for their medications, keeping a calendar for appointments and other important dates can all help with cognition and memory. If the participant is tech savvy, memory games can also help. The CDC and several other resources can be found in the resource folder on Canvas with education that can be provided to our participants. We will now focus on depression. The RHWP workflow for mood should begin during an initial visit or if a participant demonstrates signs or reports changes in mood. The evidence-based screening tools used are the PHQ-4, PHQ-9, or if there's evidence of anxiety, the GAD-7 can also be used. Education on self-management strategies should be provided, which could include a goal setting as appropriate. Referrals are made as needed to RHWP's behavioral health at Dominion Place and/or community resources. The resource finder at each site can be used as a reference. In REDCap on the left-hand side of the participant profile, you will see screening tools that can be utilized during the wellness visit, such as the PHQ-9 and the Geriatric Depression Scale. The GDS is a validated tool used specifically for older adults. It contains a series of yes or no questions that participants will answer based on how they felt over the last week. The GDS short form is more easily used for physically impaired people and mildly to moderately demented patients who may have short attention spans or feel easily fatigued, as it only takes about 5 minutes to complete. Due to stigmas associated with mental health, it's important to understand that this may be a sensitive or embarrassing topic for many. You can start the screening by saying, "Is it okay if I ask you a few questions to see what's been going on with you and how you've been feeling lately?" In REDCap, the short form is utilized to screen for depression, where a score of 5 suggests depression and further action should be taken. However, this screening tool does not assess for suicidality, so it is important to take further action or assess if a participant demonstrates a positive score. At RHWP, we prefer to use the PHQ-9 because it does address suicidality and it is used more broadly throughout the healthcare system. The PHQ-9 is a questionnaire that assesses the symptoms of depression and how often an individual is experiencing these symptoms. The more often a participant states they are having the symptoms, the more points they will score, indicating a higher severity of depression. REDCap will calculate the score for you. Scores of 0 to 9 indicate minimal to mild depression. At scores greater than 9, moderate to severe depression is indicated and further action steps should be taken. It's important to know when a participant should be screened for depression. Screening at the time of enrollment allows RHWP to establish a baseline for the participant. After that, screening should be implemented when there's a clinical suspicion for depression or the participant has reported changes in their mood. If there's no concern for depression, screening should occur annually to ensure that there have been no changes from the participant's baseline. In line with the 4 M's, we must consider all aspects of a participant's care. There are several common medications known to cause drug-related depression that we should be aware of. Some of these include antihypertensive medications such as beta blockers, calcium channel blockers like amlodipine, corticosteroids such as prednisone, opioids, benzodiazepines, and alcohol can all contribute to depression. While these medications may be associated with the participant's mentation, and we may be persuaded to recommend changes, it's important to consider the indication for each agent and the likelihood of its depressive effects on our participants prior to taking further action. A more detailed list of medications under each drug class is available in the resource folder. Once a participant has been screened, there are several strategies for preventing and reducing the risk of depression that can be discussed. It's also recommended that participants speak with friends and family to keep them updated on their lives and how they are feeling. Finally, it's always important for participants to eat healthy and to exercise. The National Institute of Health and several other resources can be found in the resource folder in Canvas, with education that could be provided to our participants. The ability to deal with and recover from adversity or stress is resilience. It's important to recognize the resilience demonstrated by our participants as they manage the complexities of complex cognitive impairment and depression. Here are a few ways to help people build resilience as they deal with the daily changes they may face. Help them focus on positive aspects of difficult experiences they've had in the past. Support lifestyle changes such as a healthy diet, exercise, and spirituality. Think about wellness and stress reduction programming. Assess access to senior centers and opportunities for meaningful activities. The stigma associated with declining cognition and depression is also important to consider as we care for our participants. Consider the following tips to reduce the stigma and remove barriers that may interfere with our ability to care for them. Educate yourself about behavioral health. Be aware of your own attitudes and behavior. Choose your words carefully. Educate others and challenge myths and stereotypes. Focus on the positive. Use the strengths perspective. Offer support and encouragement where needed. In summary, there are various tools to assess for cognitive impairment and depression in older adults. RHWP utilizes the Mini-Cog to screen for cognitive impairment, and both the PHQ-9 and GDS to screen for depression in older adults. It's important to refer participants to the appropriate resources if they screen positive for either cognitive impairment or depression. Additional resources about either condition are located in the resource folder if needed. Please continue to the post-assessment in order to complete this training. Thank you so much for listening.